Hello, good evening, everybody. Hello, good evening. Dr. Shubode, can you just kindly check that my mic is fine?
I can hear you well.
Perfect. So you're all welcome once again to today's edition of the NOA Zoom learning sessions. We're gradually running to the end of the spine and pediatric orthopedic sessions, and we should be going into the hip and shoulder lectures, and then onto the knee and so forth. Plenty of things. I want to thank everybody who has participated as faculty, who has participated as trainees as well. Thank you all for your time, and thank you all for your support and encouragement and for your feedback, which has all been working together to make the lectures just get better and better. Like I said before, we're gradually running towards the close of the PEDS and spine sessions, and we should have a kind of feedback assessment for trainees particularly, just so that we would know what we've done well so far and know what we could improve on subsequently. Again, this will be very beneficial in planning the next set of lectures, which should start from middle of next year, the next cycle, and then to start saying what should go into the curriculum and what needs to be tweaked and so on and so forth. The exact date of the assessments will be communicated to you sometime during the week. I don't think it's anything that anybody requires any fancy preparations for, really. So it's really just to, again, like I said, give us feedback and help us to see what has worked, what has not, and what areas people want to have further learning on, and so that we can plan using this information. So nothing to get nervous or worried about, and it's nothing to stress. Today we're having Dr. Didapo teach on current trends in pediatric orthopedics, current concepts, current trends, and this is really just, again, like I said, gradually us running towards the end of the pediatric orthopedics sessions. We'll have a lecture on cerebral palsy tomorrow, and we'll close up the pediatric orthopedic sessions next Sunday with a talk on brachial plexus injuries. I know these are the more obscure, less common, slightly heavier topics, and I do encourage everybody to be present and to participate in these things. Likewise, we essentially have run to the close of the spine lectures, and we'll be taking off with shoulder starting from next week, Saturday. Essentially, that's replacing the Saturday sessions that we have been having. Like I said earlier, feedback is welcome. Kindly type in your comments. You can email them, you can WhatsApp them, you can send them on Telegram, just so that we have a feel for how to make things more productive, particularly for the trainees who have been coming. And if there are persons in your institution who haven't been attending these sessions, particularly for the trainees, please reach out to your colleagues and get them to all come, because the whole aim is for us to improve the quality of knowledge and improve the quality of patient care in our subspecialty or in our specialty. So I would just want to hand over to Dr. Didapo to start sharing his slides. I don't think he needs much of an introduction, particularly for people who have been attending. Dr. Didapo.
Thank you very much. Good day, everybody. Let me see if I can share my screen. Share. Can you all see that?
Yes, we can.
Okay, I need to do this and do that. Okay. Well, thank you very much, everybody. I am grateful that you're all still here. It's been a long slog with the pediatric term. I was rather hoping that it will go quickly, but it's been, I think it's been 3 months, 4 months now that we've been doing children's orthopedics and spines. Both are not things we all do, but it was nice. It's been nice. Being able to talk through some of the children's orthopedic stuff, and the spine session has been extremely good as well, with a lot of people being involved and lots to talk about. We're rounding up, and I just thought this talk, I would just do a current trends talk. It's more of what we do currently in children's orthopedics, what's new, what's happening, what's changing, and some of it is you're going to be familiar with, and some of it you think, oh, I didn't know that that existed. I've had to give this talk at quite short notice, so I apologize for that. But I hope you find it helpful. Please type as many questions as you want in the chat box. I won't take too long with the talk, but if there's anything, if I talk about any particular thing and you really want to ask questions or you want to talk a little bit more about it, please let me know. I practice both in Nigeria and in England almost equally now, so I think I've been doing that for about 10 years, so I'm probably more than most able to speak about practice in both jurisdictions. My background, well, I'm an orthopedic surgeon. I work in England and I also work in Nigeria and Ghana. So yeah, I do a lot of children's orthopedics in Africa. That's mostly what I do. I do a lot of foot and ankle surgery, but I do some hand surgery as well. The children's orthopedics is really seriously underserved, and to be honest, if we can train our surgeons to at least do basic children's orthopedic well, the burden of musculoskeletal disease in adulthood, I think, will reduce significantly. This is why I think children's orthopedic training is so important in our environment. If I had to pick one specialty where we have to make every single trainee in West Africa go through, I would suggest everybody does 6 months of children's orthopedics, so they can pick up fractures that are likely to cripple children, and infections that are likely to cripple children, and treat it on time. These things are really important. I have no conflict of interest. I am interested in children. Children's orthopedics, the scope is vast. I mean, we've been talking for 3 months now. You've seen talks on the hip, talks on knees, talks on spines, talks on the upper extremity. We haven't done a lot of that, but we have alluded to it from time to time. So children's orthopedics really goes from head to toe. I think some of my spine colleagues have talked about scoliosis, and there are all sorts of congenital abnormalities. I remember Dr. Shubodi talking about congenital deformities of the spine, talking about vertebra, blocked vertebra. These things are really, really important. And if you understand it and you're able to treat these children on time, they do not become crippled adults. It is intellectually challenging. There's a lot of thinking to be done. And if you like very simple answers, children's orthopedics will be very difficult for you. The answers often are nuanced and not as simple as you would like them to be. Upper extremity surgery, axial skeleton, appendicular skeleton surgery, metabolic disorders and resulting influence on the skeleton, childhood injury prevention, even sports medicine. I do a lot of pediatric sports medicine in England, so I would do ankle arthroscopies, ligament reconstructions, knee arthroscopies, meniscal repairs, discoid meniscus. I do all that. So my repertoire is quite vast when it comes to children's work, and so it should be, because when you're treating the child, you have to treat the whole child. You can't just say I'm a pediatric foot surgeon and that's all I do. It's a bit difficult to just do that. The skill set you require to do children's orthopedics, warm heart, skilled and gentle hands, a lot of patience. A lot of patience. Sometimes you're just waiting for the right time to do surgery. So if you need to make money sharp, it's not for you, because sometimes you don't need to do the surgery until next year. So if you need to get some cash in your hands, please leave that child alone. Not for you. Pediatric hips are quite a big part of our practice. You've had a nice lecture from Dr. Lawani about congenital hip dislocation. We currently do not screen hips in most Nigerian hospitals, but the only saving grace we have, and I think it's changing a little bit with everybody trying to get posh, is that when we have our babies, we put them on our backs and abduct their hips. So even the babies who have had trouble with their hips, either they're dislocated or dysplastic, if you put the babies with the hips abducted regularly from infancy, then you kind of sort of treat that hip. So congenital hip dislocation, people say we don't see it in Africa. We do see it. Maybe it's not as common as it is in the West or in Canada, but we see our own fair share. Trouble is we miss it and we don't treat it on time. Screening, as far as screening is concerned, a lot of countries in Europe will do ultrasound screening for congenital hip dislocation. I think to even get an ultrasound for pregnant women is enough of a problem in Nigeria. So trying to screen all babies for congenital hip dislocation is going to be a bit of a problem. I think that going forward, our colleagues that are in charge of the scientific committee, or maybe it's the committee that deals with the legislators or whoever it is, I think what we should be doing is suggesting that when the children get their immunizations, whoever is immunizing the children should screen them for hip dislocation. I think we have to find a way where we screen our own children. I don't think that it necessarily has to be the same way other people do it in other countries. We just have to find what works for us. Why should we screen children for hip dislocation? Because the earlier you pick up a dysplastic or a dislocated hip, the easier the treatment and the more predictable the outcomes will be for treatment. If you screen the babies early and you find out the baby's hip is dislocating, the treatment is quite simple. This is a pelvic harness. You put the baby in a pelvic harness and you keep checking. If you don't have ultrasound to check whether your hip is reduced or not in the harness, you can take a plain film, a pelvic x-ray, and you keep the child in the harness and you check the harness. I used to check them every week. You can check them weekly or 2 weekly, depending on how well they fit. And then you'll take an x-ray once a month if you don't have ultrasound to check how well the hip is doing. Total time in a harness is usually about 4 to 6 weeks, after which the hip should be stable. Sometimes we put a hip in an abduction orthosis after they've been in a harness for a little bit longer. Some people will keep them in a harness for up to 3 months. I find if you keep them in a harness for too long, especially if they're not responding to treatment, usually the ultrasound scan is the best way to monitor response to treatment. You actually see the socket developing and growing over the femoral head as you scan every 2 weeks or so. But if you can't get a scan, you can get an x-ray. Take the x-ray initially with a harness in, first 2 times on every other week. And after that, you can take the x-ray with the harness off. And if the hip still stays in after about 6 weeks, then you know that you've probably treated that hip. But I don't think that's the end. I think you still have to watch that hip. In my own case, if I was treating a child with a congenital hip dislocation that I picked up in Nigeria, after I've finished with the harness over 6 weeks, I'll probably put the child in an abduction orthosis, a loose abduction orthosis that's removable. You can remove it to change the baby and all that. I would put that on probably for another 2 to 3 months, because that's removable. The child can kick and move around in it. the risk of avascular necrosis of the femoral head is quite small in that sort of harness. This is what a congenital hip dislocation looks like. How you can make out the difference between a congenital hip dislocation and other dislocations of the hips in children is that with the congenital dislocations, the acetabulum, you can see the acetabulum on the right side, there's actually a socket and a femoral head. On a side that has congenital hip dislocation, the socket doesn't actually form in this child. This child's a bit lucky because the ossific nucleus has shown up on the other femoral head. Often you don't even see that, but a lot of surgeons would wait for that ossific nucleus to show up before they would treat this child. How would I treat this child if I was in Africa? You should really ideally find somebody who can treat congenital hip dislocation and refer the child to a children's orthopedic surgeon or somebody who has experience in doing this. If you don't know how to treat this, treating it badly is much worse than leaving it. As with everything else, don't make it worse. If you can't make it better, leave it alone. This would be a walking age DDH. This child would be about 13, 14 months old. This child would be walking, but this child will be walking with a bad limp. The treatment for this is an open reduction. I would often do a femoral shortening osteotomy at the same time. That's what I do, because the shortening osteotomy makes the hip quite slack, so it stays in the socket. It's a standard anterior approach to the hip. You do an L capsulotomy. You then follow the ligamentum teres from the head right into the depth of the acetabulum, usually the inferior part, in the inferior part of the acetabulum, where it attaches to the transverse acetabular ligament. That's how you know you've reached the bottom of the socket. So you remove the ligamentum teres. Every time you ask people in Viva what's the blood supply to the femoral head, they're always telling you the ligamentum teres. Interestingly, it doesn't really supply much blood to the femoral head in small children. It does later on, but the total blood supply to the femoral head, it's not as much as you think, because in children's orthopedics, we cut it off all the time. I've never actually seen it bleed, which is interesting, come to think of it. I don't know how many ligamentum teres I've cut. I've cut a lot, and I haven't seen one bleed yet. They don't bleed, it's quite avascular. So you cut the ligamentum teres, put the head back in, and see if it stays in. And like I said, often I'll have to do a slight shortening, about centimeter femoral osteotomy, and then I have a really nice close reduction, and then you repair the capsule and put it in a hip spiker. Some authorities, if the child is over 2 years old, you do a pelvic osteotomy at the same time. There are all sorts of variations to the theme, but the important thing is you do an open reduction and a femoral or pelvic osteotomy to keep it in. If I was working in Nigeria and I didn't know how to do a close reduction, and they didn't have any money, and you didn't know who to send it to, because all these things would exist or can exist, then what you could do, I would suggest, is you can put this child on traction, gallows traction, like you would for a child who has a broken femur, for about 2 weeks, gradually abducting the hip. Every 3 or 4 days, you abduct the hip in the gallows traction. And once you've done that for about 2 weeks, you take an x-ray with the child, with somebody holding onto the leg, and see if that femoral head comes down enough. If it comes down enough, then if it comes down to about that level, the femoral head is there. But if after your gallows traction it comes down, the head is about that level, then you put that child in a hip spiker and see if it's reduced. Do not force it. Now, this is if you absolutely cannot send the child to a children's orthopedic surgeon or somebody who has experience in children's orthopedics. The best thing to do, and I would repeat, is to find somebody who does children's work and can do an open reduction on these children. Even a children's orthopedic surgeon doing an open reduction, sometimes there are still some of us who would do a preoperative traction for this. I haven't done that. I wasn't trained to do that, so I would do this single stage, and that's how I've always done it, and I've had reasonable good results with that. Slipped epiphysis. We talked about slipped epiphysis. We had a great lecture on that. It's a big problem where we're from in Nigeria. Um, the treatment of slip upper femoral epiphysis is a single cannulated screw to stabilize the femoral head onto the neck and shaft. Unfortunately, sometimes the slip is quite severe. We see this all the time. The child's been limping for 6 months, very slightly, and then they fall over, they trip, they fall into a gutter, they fall whilst playing football, and you have this massive slip, where the head completely comes off the neck. So this is an acute on chronic slip. It's a bad idea when this happens. When you see a bad slip like this, Loder's classification comes to mind. For work, for what you do when day-to-day work, really the Loder's classification, stable and unstable slip, is probably all you need for most of what you do. You need the mild, moderate, and severe slips for the anatomical extent of the slip. But in terms of functional outcome, the Loder's classification is probably as good as you will get. Because if you can't weight bear on the hip, it means you have an unstable slip. If you have an unstable slip, your chances of getting avascular necrosis approaches 50%. He reports 41%. Most other authorities, if you read them, it's about 50% if you have an unstable slip. If you have a stable slip, which means the patient can weight bear. Weight bear means that the child can actually stand on the leg without holding on to anybody or any support. That's what weight bearing means. It doesn't mean walking without limping. It means being able to put weight on that leg without holding on. That's what that Loder's classification weight bearing means. If you can weight bear, your avascular necrosis rate is low. If you cannot weight bear, your avascular necrosis rate is 50%. So this child who has this severe slip and can't weight bear already has a 50% chance of that head dying, whatever you do. So if you keep that in mind, you'll be a little bit more careful about how you interfere with it, because you don't want to convert 50% to 100%. These are varying types of slips. I mean, this one is not nearly as bad as the last one I showed you. With this kind of slip, a standard single cannulated screw done very quickly would stabilize this hip. You keep the child non-weight bearing, touch weight bearing really, for about 12 weeks. The pain would settle, and then you let it start walking. This is again another severe slip. This slip and this sort of slip are very, very difficult to treat. The child's leg is completely and fully externally rotated. Often they can't weight bear. Even if they can weight bear, they can just about weight bear with a lot of discomfort. They will limp quite badly. Pinning this in situ is really difficult, because if you want a screw in the center of the femoral head, your screw has to come in from pretty much the greater trochanter to go to the center of the femoral head. And it has to come very anteriorly as well, almost going through the femoral artery. They can be very difficult to pin in situ. In situ pinning for this can be quite difficult. Often, for this severity of slip, I would almost always do an open reduction, femoral neck shortening to reduce the tension on the retinacular vessels, posteriorly reduce it and pin it. That's my standard approach to a very severe slip like this, and I've done several in Abuja. I've probably done about 18 or so. We should write it up at some point, and that's what we would do. These are difficult situations. Over here in the UK as well, I would often do, for the severe slips with severe external rotation of the lower extremity, we would do an open reduction, femoral shortening. We use standard anterior approach. We don't do posterior approach with trochanteric osteotomy and all that. We don't do that. We've never done that. We do a standard anterior approach, a fish type osteotomy or Dunn osteotomy. We've done that for years. We actually have a paper out on that. It was published several years ago. We find that that technique works, and we found that our avascular necrosis rate we didn't increase our AVN rate, and this is another one of those slips. Those bad slips, I mean, look at that slip on that left hip here. A child's just going to really struggle to walk on that hip. That is really, really difficult. Pinning in situ for these sort of hips is just not great. I will do an open reduction, and that is the kind of result I get with my open reductions. That was an open reduction for that. So when I do my open reduction, one of the things that is new now is when we do our open reductions, sometimes you can check that you have not knocked off the blood supply to the femoral head. And how we do it is this is a probe. This is the probe that they put in people's head to measure intracranial pressure. And I think the ICU guys use it for all sorts of things as well. But because I'm an orthopedic surgeon, the only thing I can use it for is bones. So I use this for when we do our open reduction, our anterior open reduction, anterior approach, open reduction, femoral head, femoral neck is somewhere there. We've done a T capsulotomy to get into the acetabulum. We've let our posterior retinacular vessels, posterior capsule, everything is left completely intact. We don't mess with it, we don't touch it. We then do the femoral neck osteotomy about there. We then reduce the head, the neck onto the head, and then we fix it with a single cannulated screw coming from about there. So we can put a K-wire into the head, and then we'll put a probe into the head, into the femoral head, once we've reduced it, and then we look at the waveform. We look to see whether there's any waveform in the femoral head. Now, if that is flat, that's like a flat ECG. That's like you're dead, man. But if that's got waveforms on it, it means that there's pulsatile flow in the femoral head, and that femoral head is viable. So we didn't do this originally. I've been doing this for a long time. And it was only in the last 5 years or so, one of my younger colleagues joined the team. And he said, why don't we try this? I said, yeah, sure, why not? So we got the probe out, and it actually does work well. We put the probe in before. In fact, sometimes we put the probe in before we do the reduction, and you'll find out there's almost nothing in the head. We then reduce the head, put the screw in, and then you put the probe in. Absolutely fantastic. The other way you can do it is you can actually put the probe in through the cannulated screw. You feed it up through the cannulated screw. Once you put the screw in, right up to the head, and that gives you the same waveforms. So that's one of the things that has changed so far. 1 or 2 screws. With the open reduction, very occasionally you'll need to put 2 screws, but usually 1 screw is enough, whether you do a closed reduction or an open reduction. When I do an open reduction for those severe slips that you've seen, I just think it's only reasonable for these children that you don't really, one hip, you already don't know whether that hip is going to get K-leg. I think it's only reasonable whilst you're in theater that you pin inside to the other side, except if the parents are absolutely against it. I almost always do a pinning inside to of the undisplaced side because I don't want any stories. Because even here in England, where they don't pay for care, sometimes the other hip displaces and the parents don't bring the child on time because they don't have taxi money. I've had that happen before. The thing went from a very mild sleep to a rather severe sleep on the other side because the mother couldn't be bothered to find taxi money to bring the child to a hospital. So if you get these children, always think in terms of what else is going to happen to this child that I can prevent before some hapless parent who doesn't really care enough puts the child at risk more than is necessary. So when I started out in practice, it was always the nice long conversation of, pinning inside to, let's not pin inside to, let's pin inside to. These days, as you get older, you just think, look, the interests of this child is paramount. And somebody has to look after this child's interest. And ideally, most children who've had a severe slip on one side, I would urge that you probably just pin inside to the other side and don't let the same thing happen again. Chances from your Sufi lectures that we had, the chances that you will slip the other side is from 50 to 80%. So it's a big chance that you're going to slip the other side. Other pediatric hip conditions, we've talked about infection, we talked about the Cocker criteria. If your white count is high, child can't weight bear, white count, HSR is high, you already have 3 out of 4. That child probably has a septic hip. You should be opening up that hip, washing it out, putting the child on antibiotics. Perthes was also talked about, an idiopathic coxa vara. This is You get an X-ray like this child is limping on the right hip. You look at the X-ray, and a lot of people would not be able to pick up what's happening on that X-ray. Well, that X-ray this is the best time to pick up perthes. This is why you really must, you get a limping child. If a child walks into your clinic, they say, oh, this child is limping. The most important test, if you have to do 2 tests on a child who's limped, walked into your clinic, get a full blood count and get a plain X-ray of the pelvis on both hips. So that will check your white count, and that will check to see whether there's any hip pathology. You will immediately rule out the most urgent things that you need to rule out for a septic hip. The most urgent things that you need to rule out that will impact the child's life long term. Okay, so you take a picture, and in the early days of perthes, when this hip looks nice and round, then you look at this one, you follow it round, and you see that line. Now that's a subchondral fracture of the femoral head. It's one of the earlier signs of Perthes disease when it's starting to collapse. The subchondral fracture. The interesting thing is that subchondral fracture affects about half of the femoral head. So under the Salter-Thompson classification for severity of Perthes, that's a B. B means bad. Bad means you need to do something about this if the child is about 5, 6 years and over. What I would often do is a femoral osteotomy. It reduces the natural history of the Perthes and makes you get a nice round femoral head once it's healed. So beware of Perthes. Pick Perthes up really early. If you can pick a Perthes up early and you treat it early, the outcomes are much, much better from the published literature. You look at this particular X-ray and you're trying to make up your mind, is this infection? What is this? Is this PFFD? Is this infection? One clue, always look, is there a socket or no socket? Is there a head? No head. Once you have a socket and you have a head, and the head is in the socket, it's not DDH. So here we have socket, we have head, bit of neck, and then nothing. So this is a proximal focal femoral deficiency with a pseudoarthrosis between the femoral shaft stroke neck and the rest of the neck. So that's a big problem, this one, because you have to try and somehow find what's left of the neck and the shaft. You have to find a way of bringing this to this, getting it to join up before you even start talking about limb lengthening. When you're talking about pediatric deformities, there are some things are of greater priority than other things. If you haven't got a hip joint, there's no point having a leg. So your hip has to be okay, then your femur has to be okay, then your knee joint, then your tibia, then your foot. That's how this thing is designed. So you got hip, then you got thigh bone, then knee, then everybody sits on what's on top of it. So you've got to fix your hip joint first, this child, before you start moaning about how short the femur is. If you can't make the hip normal, you've lost. Okay, so you've got to get the hip right. Next one. Sorry, I'm trying to admit people at the same time. So that's another one, infection of PFFD. Well, you can see femoral head, nice socket, nice femoral head, and then nothing. Well, obviously, this is a proximal focal femoral deficiency. This one's easier than the last one because you can actually see socket head. So if you can manage to get that to join up to that, then the biggest problem you're going to have is a short femur. And if you're lucky, you can lengthen it up in 2 or 3 stages, and you can get a reasonable length femur. But the problem with these PFFDs is there'll be other problems. You'll probably have no ACL, no PCL, so the knee is going to be slack. And if you're really unlucky, you'll probably have fibula epimelia with it, and then you'll probably only have 3 toes, and then you're all screwed. You know, they're very difficult. Once they come and bring this child to your clinic, you got a friend for life. You and that child are stuck. So you're going to be just doing bits and pieces. You have to plan, okay, which surgery are we going to do before school? Which one are we going to do in primary school? Which one are we going to secondary school? That kind of thing. So you have to have parents and child that you get along with to be able to get the best outcome for this child for the rest of his life. you have to want to look after these people, to look after these sort of people, because you're stuck with them for a long, long time and you got to look after them. This is a different condition. This is a different hip pathology in a child. This is idiopathic coxa vara. I spent quite a bit of time talking about it. It's a congenital abnormality of the proximal femur in children. It's actually a dysplasia of the metaphysis of an idiopathic nature that affects the proximal femur, sometimes unilateral, sometimes bilateral. I've seen both. Usually the child walks with a bad limp on one side if it's unilateral. They walk with a waddle gait on both sides if it's like a duck-like gait, like a duck, duck, right? So they walk with a duck gait, and you see a child walking with a bilateral waddle gait. They either have idiopathic coxa vara on both sides. Sometimes they have DDH on both sides. So you actually will need an X-ray to tell the difference. But once you have a socket, a nice round socket with a head, it's not a DDH again. It's something else. So think about other things that it can be. There's lots of pediatric pathologies out there that these things can be. That's idiopathic coxa vara again. This one has been left for a long time. If you leave it and you don't treat it, you actually damage the hip. This is bilateral. One side is worse than the other. You can see the neck shaft angle on this side is less than 90 now. This one is still 90 on the left side. On the right side, it keeps going until eventually this, if you don't treat this, this is going to end up on the pelvis and the head will stay here. And then it becomes really, really, really difficult to treat. So these are conditions that you must keep in mind. Idiopathic coxa vara, if you don't treat it, the hip will fail, the child will become a cripple. The treatment is simple enough. You need to do a valgus osteotomy, correct this neck shaft angle from 90 degrees to 135 degrees. That's all. However you do it and however you fix it is your business. But what you want to do is you want to make this neck shaft angle from 90 to 135. The best way to do it is a pediatric hip screw. There are pediatric blade plates as well, so you can use that. I mean, it's all about taste, I suppose. But the pediatric hip screws I've found over several years of using all sorts of things are the easiest way to do it, the simplest way to do it. You put basically, if you've seen a DHS before, this is how I do this. This is really simple. This is really easy surgery if you have the right tools. You have to have an image intensifier. You can't do things blind in children. You'll kill them. You put wires everywhere. So you need an image intensifier, okay? You put a guide wire in there like that. This is how I do it. It's really, this surgery takes me literally, I mean, a lot of our guys have come to Abuja and watched me do this surgery. This surgery, if I'm doing the surgery myself, takes me 25 to 30 minutes. It's that quick if you have the right tools, pediatric DHS. So I'll put a guide wire. I would even take the difficult side first. I'll put a guide wire in there, okay, measure the length of my screw, put my lag screw in. Often with this one where the growth plate is sliding off, I would advise that you put the screw in the head and hold on to that growth plate, because the whole thing will fall off. So there's no point you trying to miss the growth plate. You have to cross it. Even on this side, if somebody were to cross the growth plate, I won't quarrel with them, because these things are quite difficult to treat and the recurrence rate is quite high, especially if you don't use a hip screw. So you put the hip screw in, I measure it, tap, put your lag screw in, then I'll do an osteotomy here. Now I'll do an osteotomy here and then take a wedge out. You can take a wedge like that, and then when you close that wedge, you bring the femoral head up. Now, how much? I don't usually trouble myself. I just put a 135 plate on it, and the 135 plate corrects the whole construct to 135 neck shaft angle. You may have to take a bit more, a bit less of bone off to make sure that corrects. And then you just put the side screw on the side plate, and that's it. It's done. It's actually quite quick with a pediatric hip screw. If you are putting those angle blade plates in, those pediatric blade plates, this is an absolute disaster. It'll take you forever. You'll be there. You'll be calculating this and calculating that and calculating the other. You will sleep there. You'll spend 3 hours, and you will wish you hadn't started. So those things are really difficult for correcting severe deformities like this. You can do it, but you've got to make sure that you've now drawn everything on a piece of paper, get your angle blade plate, because even with that, you're still going to sweat. So do the easy thing, trust me. I've done it both ways. One is easier than the other. This is just a quick slide on Staheli looking at neck shaft angle on knee angles, tibiofemoral angles, and all that for Blount, and knock knees and bow legs. And you have to understand that this graph that Staheli drew, tibiofemoral alignment chart, all children are born barrels. This is where you get all your bow leg from. All children have bow leg, and then by the time you're 2 years old, your bow leg should have disappeared. You should have knock knees, and you get knock knees. Your knock knees get really bad. So by the time you're like 3.5, 4 years old, you have maximum knock knees, and then you get to age 4 or 5 or thereabout, your knock knee disappears, and you got a normal valgus angle. I would contend that this was done in a Caucasian population, and if we repeat these studies in our population, I don't know whether that work has been done or not. And I would love somebody to tell me that, yeah, we've done it in Africa. We know what our own results are. And this is something anyone can do for his master's thesis or for his West Africa or Nigerian thesis. Just gather a whole bunch of children together in the pediatric. You just go to a few pediatric clinics over a while and generate this chart for us, because we don't have our own data, And then my own thoughts, and I would love somebody to prove me wrong, are that our graph is behind this graph by a good 6 months. I suspect our own children are like this, are here. We run roughly the same, but we're behind by 6 months, like that. And I would wager that that's what we would find in our own population, because that's the sense I get for what we see in Africa. I think that our bow legs occur earlier. They resolve maybe not quite as quickly. So our graphs are slightly different, ever so slightly different from what we're seeing here. What's the point? The point is, we're working on the basis of this chart. Our children's bow legs are maximal earlier, and we're waiting for them to resolve at the time that white people's bow legs resolve, but they don't. And then we're getting a lot of Blounts we're supposed to be treating, and we're not treating. We're waiting till 4 before we start treating Blounts. You can see how many years behind we are. I actually think that we're behind by 2.5 years if you're waiting till 4 to treat your Blounts, And this is what I mean. So you see a child like that in Africa, a child like that that's white, that maybe I would allow you to be like this as a white kid until you're 2.5 years old, before maybe 3 before I start worrying. If you're black, if you're like this at 2.5, I'm already worried. I want to put my 8 plate in, get you straight quickly before we start getting into trouble, because we'll get into trouble quite quickly. This is another one. This is what happens when we sit around and wait till the child is like 4. You start getting this kind of x-rays at 4 years old. Sometimes you get this x-ray at 3.5. It's really bad, You see kids, the medial tibial physis is already crushed and crumbly. And then you want to do 8 plate here, and you expect it to work. When this child stands, the whole leg is in varus, The mechanical axis, when the child is standing out here. The amount of force that's generated, that's squashing and compressing that growth plate, is absolutely phenomenal. So just simply putting an 8 plate here is not going to help you. You're going to have to put an 8 plate, correct the mechanical axis by doing osteotomies so that the leg is in valgus, so that the mechanical axis and the loading of the femur and tibia epiphysis is on this side, so that this is offloaded. And hopefully, if you have some luck, it might recover. I would suggest, the only trouble is always money. For these kind of children, you really should get an MRI scan of the knees just to see if that growth plate, that physis, is closed. Even with that, except you get a really high resolution scanner, you may not be able to tell. A CT is probably not a bad idea, but you need to make sure the radiologists know to cover the child really, really well. Because I don't like CTs on children, although CT on the knee is not a big deal if the child is properly covered in terms of radiation. Because you need to know whether you got a bar before you even start treating this child. Otherwise, you don't know where you're going to end up. And look at that. I mean, that's really, really bad. This one, where do we start? I mean, for those of our colleagues who do a lot of limb reconstruction, I mean, where's the cora here? I mean, the cora is right here. That's center of rotation angle. That's where the apex of the deformity is. Apex of this deformity is here. So 8 plates, doing osteotomy in the tibia, putting a frame in the leg, total waste of time. Look at the femur. The femur is deformed. Look at that femur. Look at that femur. You know, it's deformed. So you've got to correct the deformity of the femur, you've got to correct the deformity of the tibia. Otherwise, you're not going anywhere. You got to do an osteotomy of that femur, take a wedge out so that you can recreate a horizontal. Look at the joint line. Joint lines that way. For you to have any chance of making this person better, you got to have a joint line that's like that. Look at that joint line. You want to recreate that. Look at that. That's what you want. That. If you want that, you've got to do an osteotomy, closing wedge, medial closing wedge of that femur, bring the joint line back up, and then you have to now start fighting this tibia. I mean, that's a bar. You can't do 8 plate here. Your osteotomy of the tibia is not going to correct that because your deformity is here. So you've got to do an osteotomy here. So here, I would often do an osteotomy here. Take out that triangular wedge of bone, close that, put a plate on. So I've been doing it anteriorly now. I used to do it laterally. It's such a faff. Just cut straight, and that's less problematic. Cut on the side. Done it medially. I've done it medial, anterior, lateral, same thing. The direct anterior is quicker, less problematic. And then you get to the tibia, you have to do an intra-articular osteotomy. Well, almost intra-articular. So your osteotome's got to go that way. And then you got to elevate that to match the recreated joint line. And then you fix it however you think you need to fix it to stay. And lots of different ways of fixing that. And look at that again. Once you get growth plates that are crumbly like this, you're never going to win. You've got a physial bar. You've got to decide how you're going to address that. Sometimes if you get it on time with a younger child, you can do a physiolysis. You take out the stock physis, put an 8 plate there, correct the tibia deformity with an osteotomy, and hopefully that will start growing again. Sometimes they have, sometimes they haven't started growing again. They've stayed stuck and about to do a second osteotomy again. So these are difficult. These are really difficult problems. Look at this one. Come on. This is true story. This is one that I saw. Someone did this in Lagos. Somebody was trying to correct Blount's, and you do need to understand what you're doing before you do it. If you don't know what to do, ask. You've got lots of colleagues. This is why we've got lots of different forums where we can discuss cases, get advice of your colleagues, ask somebody what they think, before you start interfering with people. Somebody did this to a kid, saw the Blount, something similar to this. What did they do? Think about it. You have something like this, and what have you done? You've now gone and done that to it. Look at that. So that kid's gone from that to that. That's actually the same patient. Gone from that to that. What did I tell you? There's no way you're going to correct that without recreating a transverse joint line. Joint line that's perpendicular to the long axis of the femur. And then you're going to have to do an intra-articular osteotomy here. You already have a physial bar here. That's stuck. That's not going to grow again. That's not going to recover. It's bone. It's stuck, as in stuck. S-T-U-C-K, stuck. So what do? And this femur is deformed. That's too long. That's too short. What do you then do? You put an 8 plate where it's where you're not supposed, if you're going to even use an 8 plate, that should be on that side, even though it still wouldn't work. But you just made it worse. You made it so much worse. Put an 8 plate over here, which is completely useless because that's stuck anyway. And then you then put an 8 plate on the lateral side of the femur to make that deformity of the femur that much worse, So again, this is really not great. I mean, this is somebody that doesn't understand what the problem is. So don't rush. Look at the problem really, really closely and carefully. If you don't understand the problem, read around the subject. If you've read and you have managed to confuse yourself, ask your colleagues. Send somebody a WhatsApp message. There would always be somebody that's, even if he doesn't know, we say, why don't we ask so and so? And there's foot and ankle forum, there's pediatric forums, there's arthroplasty forums. You've got colleagues, they'll help you. Just post a picture. Somebody will give you a reasonable answer. This is not a good answer. So this child now had to have, several osteotomy femur, and I think a double osteotomy of the tibia for me to get this right. It's straight now, but it was a lot of work. Genovalgum, if you get it on time and the growth plate is still open, you put 8 plates. You need about a year and a half of growth left, and you'll get this kind of correction. It corrects really, really quickly. 18 months and the legs are straight, you take out the 8 plates. Genovalgum responds better to 8-plate correction than Genovarum. Reason: mechanical axis, mechanical axis, mechanical axis. Mechanical axis and the pressure of the weight on the growth plate is far more important than you think. The same way you can do epiphysiodesis to correct deformity in lower limb, you can do it in the spine as well with scoliosis. And I don't know whether we're doing this in Nigeria yet, but you can put epiphysiodesis on the, so if you got scoliosis or you got concavity like that, convexity like that, it means that this side, the growth plates are growing quicker than the growth plates on this side. So you do epiphysiodesis on this side starts growing, the spine curvature reverts to normal, and it's worked. But they've not managed to make it work as consistently. Number one. Number two, for you to do this, you've got to do the way they normally do it is you deflate the lung, thoracoscopy, deflate the lung, and then you look for the growth plates on the vertebral bodies, and then you can put staples in. It can be done, and there are still centers, especially in the US, that are still doing this work. But you need a thoracic surgeon to deflate the lung for you, and most of the time this is done thoracoscopically. Elbow supracondylar fracture. What's new? Well, what's new is let's try and stop in our own environment this epidemic of children losing their limbs. It won't stop until we make enough noise and we try harder. If you see a child with this and you don't have C-arm, image intensifier, please put this child's arm in an elbow with the arm straight, extended. Do not put in flexion, put it in extension. You can put it on gentle skin traction in extension on a pillow. That would work as well. Skin traction with a crepe bandage, that would work as well. That's better than trying to force this into a cast inflection. You can imagine the blood vessel is doing that. If you flex that, it gets worse. If you leave it extended, especially with traction, gentle skin traction, that gradually reduces. Even just in extension with a back slab, I would much prefer that than heroic surgery that you don't know how to do. If you are going to do surgery, you need an image intensifier, you need a wire driver that's easy to use, and you need to know how to reduce this. It's easy enough to do. Dr. Lawani presented an excellent lecture on this. If you haven't seen it done before, it is difficult. If somebody's taught you how to do it and do it well, it is actually very easy. But somebody has to show you once or twice, and then it's really, really easy. I've seen people spend 2 hours trying to reduce and pin this. When I was in training, a lot of my trauma consultants hadn't done kids work, and they would spend 2.5 hours on this, and then they'll open it laterally and medially, and then once they open it laterally and medially, it's a disaster. It gets worse from there. Then the bits want to fall out, and everybody starts swearing at everybody else. Once you start yelling at your assistant, start yelling at your scrub nurse, you know you've lost the plot, and then you kind of don't know what you're doing anymore. Because if you know what you're doing, you won't yell at everybody. So if you don't know what you're going to do not, I repeat, do not open these fractures. Do not open these fractures if you don't know what you're doing. Put it in traction, gentle skin traction, in extension. The child will do far better than any surgery you might want to do if you don't know what you're doing. The close reduction is actually quite straightforward once you've been taught. And percutaneous pinning, lateral and medial wires, or 2 or 3 lateral wires. And this is how to do it. Can't do it like this, leave the child in traction. Far better for the child. And that's how to do that. The consequences of going to bone setter and then tying rope on this, bone setter tying rope on this, or tying rag on this, or tying juju on this, is the equivalent of you putting this in a flexed back slab. It's the same consequence. The consequence is this. And thankfully I haven't seen this a lot recently. I haven't seen this now in Nigeria for a bit. But when I started coming over 10 years ago, I saw quite a lot of this. It was horrible. I had to do a lot of remedial surgery, wrist arthrodesis, finger fusions, just to try and get the upper extremity functioning again. This is the epitome of Volkmann ischemic contracture. I mean, it happens everywhere on the planet, mind you. I mean, I've seen it happen in Canada and the USA, and even here in England. We have had in other hospitals episodes of people who've had Volkmanns. And again, it's the same thing that causes it: not paying enough attention, flexing the elbow when you should extend it, or just doing surgery that really you don't know how to do. So you spend 3 hours pulling, pushing, pulling, pushing, pulling, pushing. By the time you're done, you've shredded the boy's periosteum, the muscle, everything. You get that. You get Volkmann's, and the child pretty much lose. If they don't lose the arm completely, they lose the function. He's lucky. In a lot of the ones that we see in Nigeria, they cut their arms off. That's for a supracondylar fracture. That's a really dreadful outcome. You're better off with your cubitus varus, valgus, or whatever than an arm that looks like this. This is another one of them Volkmanns. It's really horrible. And that's the rag that some body tied on this. Really horrible outcome for something that's eminently treatable. Forearm fractures, same problem, be careful. If you get a forearm like this in a child, the treatment is close reduction and plaster cast immobilization most of the time. You will, and I repeat this, if your reduction shows that both bones line up, but you've got a bayonet and the bones are overlapping, they can overlap as much as they want. As long as they're both straight, in a child this young, this is going to remodel. The most important thing is the bones line up with each other and the interosseous space is maintained. As long as you maintain the gap in the interosseous space and this doesn't encroach into the space, that doesn't encroach into the space, you'd have perfectly normal function back. It might take a long time for the arm to remodel fully, but you'll have perfectly normal function back. What's the best way to treat this? If you've got the equipment and the wherewithal and the CM flexible rods, I would rod this in this child. The outcomes are just better and the recovery is quicker. And the child's back to whatever they want to do, sports, everything else, a lot quicker. Just because that's the nicest way to do it doesn't mean that we all have to do it like that, because we don't have the same resources. But it's nice to know that that's a nice way to do it. Can you do this without CM? You shouldn't. If you do, then you have to make sure you do it open. You can't do it closed. Pediatric fractures, this is an absolute disaster. If you ever get something like this, find somebody who knows what they're doing to help you, because you're in trouble here. You're in trouble here. I don't know where the vessel is. Interestingly, this child actually came in with a pink hand. You've now got a floating elbow. So this one, I'm sorry to say, but you would have to find somebody to send this to, because you really cannot treat this in the back slab. You should put the arm in extension, an extension splint from there to there, and transfer to somebody who you think can fix this for you. You have to fix the elbow, sacroiliac fracture, and you have to fix the forearm. And that's what we did here. We did a close reduction. I think that's what I did. I did a close reduction of this elbow fracture. I think I put 4 wires in, lateral wires, all of them. And then I did a flexible rod for the forearm. You've got to stabilize it to allow the severe soft tissue injury to start to recover. So that's what we did. We did flexible rods for the femur and radius, and we reduced and fixed the supracondylar fractures, closed, and we put K-wires in. I think I got, so yeah, you can put as many wires as you like in this. I put 4 in. Don't ask me why 4. I just thought the injury was so bad. I put 1 for lock, and that's the forearm fracture. Lateral mass fractures. Lateral mass fractures in children, it's easy to miss them. And when you miss a lateral condyle fracture, this is what you get. You get a non-union of a lateral condyle fracture. You get valgus instability of that elbow. The elbow is unstable. You know, it doesn't stay in one place. Valgus instability and gottardial ulnar nerve palsy. They start getting tingling and pins and needles in their little fingers. And the children tell you that the finger is tingly, the little finger is tingly, and the elbow is unstable, and sometimes painful. In the same month, I saw one in Abuja and one here in England. Same month, I treated one in Abuja, and I flew, I landed, and my next clinic here, I saw another one. They were both children were 8 years old, and both had a fracture about 3 years previously, and they had both been missed. So it's not only these fractures are missed everywhere. The treatment for this, I think somebody needs to be muted. The treatment for this is you've got to fix that. That's a non-union, so you've got to stabilize that. Usually you have to put a screw there, and then you need to do an osteotomy to correct the valgus malalignment. The elbow is usually in a lot of valgus, and you need to correct the valgus malalignment of that elbow at the same sitting. So that's what I did with that. So screw to fix that lateral condyle mass back, and then an osteotomy, a varus osteotomy of the distal humerus, and I fixed that with a 4-hole plate, and that's it, with it united. Elbow completely normal function. You can still see the slight cleft in the elbow joint there, the articular surface, that's fine. Gottardial ulnar nerve palsy had disappeared, and the elbow went back to normal function. I've treated a few of these like that. Pediatric femur fractures, if you have flexible rods, is a better way to treat it. If you don't have flexible rods, traction is fine. It's just that the kid, the parents, everybody are going to be in the hospital for a long time. If you've got a multiple fracture situation, broken femur, broken knee, maybe broken femur, broken something else, I would suggest that you probably can plate that, because if you've got polytrauma, just to improve and speed up the recovery of that patient, you probably should put a plate on. And that's a flexible rod for that. And that's standard practice. And I think a few centers in Nigeria do that. Of course, you need CM for that. You need the equipment for it. If you don't have the equipment and CM, you can't do this. You can't do this blind. You just can't. Okay. Distal tibial fractures, external fixators are useful for this. It's too low for anything else. To be fair, I mean, I've treated these fractures with a T-plate. I mean, I just kind of don't like X fixes. If I can stay away from them, I will. So I would put this fracture is so low, so you can treat it in a cast. I mean, if it's closed. If it's an open fracture, then I suspect you don't have a choice but to put that external fixator on. If it's a closed fracture with multiple injuries, then I'll put a T-plate on this. That's what I would do, my own preference. But there's plenty of options here. Should you fix the fibula? If you reduce the tibia and the fibula stays straight, you don't need to put a plate on the fibula in a child. Foot conditions, we've talked about club foot. I have talked about flat foot as well. We will probably talk about a lot more foot conditions when we come to the foot and ankle term. at the beginning of next year. We talked about severe untreated clubfoot. Severe untreated clubfoot, you can do the Ponseti cast. The trouble with clubfoot is we just put all clubfoot in the same box. It's clubfoot, and I can manipulate. I can manipulate this and manipulate that. They're all different. The spectrum is from mild to quite severe. You see that spectrum of clubfoot you see in the little baby? It's the same spectrum when they come to you at 8 and 9 and 10. You see some 8-year-old clubfoot, you hold it, and you know that you can cast this and you can get most of your correction. And you see some other 8 and 9-year-olds, and you know, forget it. Your casting will help you to stretch out the soft tissue, but you will not get any correction with this clubfoot. So the spectrum is extremely diverse. So saying that, yeah, we can always treat this with casting, no, it's not true. Some will not respond. Actually, quite a bit will not respond. Just like in the normal clubfoot. And the older you get, the less will respond to casting, but you should always cast still, always. And for the older population, you're going to need a little bit more surgery. Apart from just Achilles tendon lengthening, you will need a little bit more. It is unlikely that you just need only Achilles tendon lengthening. Some of the foot we're looking at, some of them, if you take your history properly, a lot of the patients will tell you when this child was born or when I was born, I was told I didn't have a problem. So sometimes you're not actually looking at a clubfoot, you're looking at a neurological condition that has developed over time. But the trouble is we'll lump everything together, we'll call everything clubfoot. And we apply the same treatment to all of them. One of the things that we need to start doing is start categorizing some of these conditions. And that way we can find out how effective our treatment is. This particular patient had quite a few months of, this was a classic clubfoot, had a few months of casting. I had about 6 to 8 weeks of casting, weekly casting, before she had her surgery. And then eventually had surgery. I think I did a triple fusion here with transfer of the tibialis anterior tendon to get this position. She's absolutely delighted, wear shoes, and have boyfriends now. And that's sometimes they look like that. Sometimes they're clubfoot, sometimes they're not clubfoot. Sometimes the parents will tell you, nope, the foot was normal when they were born. And I've heard that story several times coming out of Africa. Tibial tendon transfer, keyboard decancellation, or lateral column shortening, osteotomy of some sort. I'll usually hold them with K wires when I'm out and about in Africa, because you want the wires to come out. You're not going to be around when they come out, so anybody can pull out the wire. A lot of the cast technicians are quite good. They pull out the wires, they put another cast on for you. This is one of the things I talk about. These people will tell you that when the child was born, sometimes they will tell you the child didn't have a clubfoot. Sometimes they have a clubfoot. Sometimes it's polio, paralytic foot. They'll tell you, no, the foot was normal. If you stretch this and then you do, of course, this will respond to casting and then tenotomy. But the trouble is, if you cast and tenotomize and then you discharge the child, you haven't done them any favors. This foot will need to be braced long term. You need to put an AFO on long term for this foot to work, even after you correct the deformity. And this one is a bond contracture. This is just a deformed foot. Growth problems. This is a dysplasia of the skeleton fibrous dysplasia leading to a leg length discrepancy. This one gave me grief, actually. I spent years looking after this child. And we tried to correct the deformity of the distal femur with 8 plate. Didn't work. So this is one of the new developments. So we put a growing rod in, Faisal Duval rod. This is a growth rod. It's the kind of rod you need for children with osteogenesis imperfecta. And I was rather hoping the company would sell us some rods in Nigeria, but they're not happy to come to Nigeria because obviously we can't pay them. Each of these rods is 4,000 pounds. This is 4,000 pounds. This is 4,000 pounds. That's 8,000 pounds, just the rods. So that's why we don't have them. The advantage of these rods is once you put this rod in a child with this kind of condition, or with say osteogenesis imperfecta, that's it. That rod continues to grow as the child grows. You don't have to keep re-rodding every time they break something else. So you can leave it in until they're about 12, 13, 14. And when they reach skeletal maturity, a lot of these children don't have fractures anymore. So these are growing rods. And if you want to do growing rods are different from lengthening rods. These are magnetic growing rods or lengthening rods. Okay, this one's got a little magnet in it. So you put the rod in, do an osteotomy, lock it top and bottom, and then you put a little magnet there 3 times a day, and it grows the femur 0.3 millimeters every time you put the magnet on. So you put this on, and this is absolutely revolutionized children's care. There was a talk given by the limb recon guru from Baltimore, John Heisenberg, and he said, if I can remember his talk, he reckons that their frame use fell probably over 50% following them using this rod. So their preferred option now is do an acute correction of the deformity with a plate, something like that. Make sure the bone is straight. Once that's healed, put this rod in and they get their length, because it's so much easier for the child. Then you don't have children in frames for 1 year, 2 years, 3 years. Being in a frame has devastating consequences for your quality of life. And what they've been trying to do is get away from that. And this has been helpful. The fit bone is the alternative to this. They do the same thing. The fit bone has a wire that goes through it, and then you got to put a little, almost like something that looks like a pacemaker under the skin, and the magnet goes on top of that to do the lengthening for you. This one, the magnet is inside here. With the fit bone, I suspect the magnet is over here. The driver processor is over here. They've stopped us using the precise in children for a while. I think the medicine MHRA is looking at magnets in children. We haven't seen any problems, but there's a temporary halt using this. But I think it's still being used all over the planet, and the fit bone as well. This is really useful. Every single pediatric orthopedic surgeon should learn how to use this. In fact, some of the adult trauma surgeons are using this because when they're doing their bone transportation, rather than use a frame, you just put one of this in, lock top, lock bottom, do your corticotomy and start lengthening. So they're going away, especially in the femur, they're going away from using frames to using this to do this. So watch this space. What's the problem with this? Well, cost. Each of these nails is 15,000 pounds. So until I can find a patient who's going to be willing to pay 15,000 pounds for the nail plus transportation costs, I probably won't be able to do this back in Nigeria for a bit. And that's a precise nail. That's a magnet. Just put it on top of your leg once a day, and it just lengthens it for you. And that's that same child. You can see how much bone I've lengthened it by. So I've gone from there to there. I think I did about 5-6 centimeters on that femur, and that was done within about a month, something like that. And then you leave the nail in, it consolidates. It's really the best way to get leg lengthening done. Yeah, 5 centimeters in 1 month. Scoliosis, that Dr. Shobody, the same magnetic rods you have there, sometimes in children that are still growing, you have growing rods. And you can use this to kind of straighten out the spine in scoliosis as well. But obviously, I don't do this surgery. My colleagues do it. And we'll ask Mutalab if they've managed to put any of this in Kano. It's quite popular in our pediatric population here. I don't do pediatric spines anymore. So I wouldn't be able to say much about it, except to say that it's actually changed how we look at pediatric spines. So rather than fusing children's spines, you just do a limited fusion on the top and bottom, and then you keep the spine growing by using these growing rods in the spine as well. Upper limb problems is still in the purview of the pediatric orthopedic surgeon, but you have to have some hand experience. This is a hand with Apert syndrome that needed correcting. We had this had the surgery done in Abuja. So all these children have had their surgery done back at home in Nigeria. So there's no reason why we can't do any of these back at home. You guys should go out, learn how to do this, and go back home and offer this service to our population. They desperately need it. She's had hand surgery done and she's doing really well. This is a radial dysplasia. We've had quite a few of this as well. We've operated on some. Surgery's gone really, really well. They don't have a thumb. They have an ulnar only. Sometimes they have a bit of the radius. Sometimes they have the whole radius, except the wrist. Sometimes they just have about half of it. Sometimes they have rudimentary thumb. Sometimes they have no thumb at all. They will always need reconstruction to put their hand back at the end of their ulnar. So centralization or ulnarization of the hand. It's a rather complex upper extremity operation. It takes forever. I don't particularly like doing it, but you don't have a choice. Sometimes you'll have to do it. Um, so um, upper extremity conditions, we have a lot of this. I've seen quite a few actually. They do need treatment. There are lots and lots of things we can do to help them. Stretch, brace, and then surgery. They almost always need surgery, which consists of tendon transfer, ulnar nerve release, osteotomies, all sorts of things. It's not surgery that I can describe in like 2 seconds, but we do them. Arthrogryposis, again, we see this as well. I saw a lot of this in Ghana. I think it's less in Nigeria, but I don't know because I don't work in any of the big teaching hospitals and see the crowd. So I don't really know how bad this is. This child was really badly affected. I have permission to use the picture. The wrist had to be done first, then the foot has to be done, and this is really incredibly difficult. That's some of the conditions you see with arthrogryposis. Very difficult deformities and very difficult surgeries that need to be done to get these children to stand up and walk. And there was one particular year I kind of did 20 arthrogryposis children in about 4 days, various operations to try and get the children to stand up and walk. It's a lot of this work that we need to do, and there's a lot that we need to learn and teach the rest of the world about these conditions. This is marble bone disease, osteopetrosis. Pray never to meet one of these, especially if they've got a fracture. All your drill bits will break. All your K wires will break. All your power systems will turn to smoke. You will cry. So if you see one of these, do not even start until you get a Midas Rex kit with diamond-tipped burrs. Otherwise, you'll just spoil everything. Okay, they don't have osteocytes. They have osteoblasts. They lay down bone. The osteocyte that's supposed to melt the bone doesn't melt the bone. It's gone to sleep. So the bones just keep getting built up, and it's really dense. It's dense, but it's brittle, so it breaks, and then you can't drill through it. They don't have a medullary canal, and sometimes because they don't have a canal, sometimes it affects production of blood and blood products, and that's part of the problem they have. Spines. I'm not a spine guy, but I just thought I'll put this interesting this interesting spondyloptosis, they call it. So once you are falling off, and you're tired of falling off, you then fall off completely. It's called spondyloptosis. They have quite marked problems with nerve roots, S1, S2 nerve roots particularly. Sometimes they start to get bowel problems and all that. And then you have to do a decompression. You have to reduce that. Some surgeons believe in reducing it slowly. Some reduce it on the table, and then you have to stabilize it with pedicle screw fixation. I think this is becoming standard practice where we are now. You can see that that's been reduced eventually and fixed. Sometimes the reduction can be quite difficult. I think they got lucky here. Sometimes it's easy. Sometimes you have to fuse it inside too, because if you try and reduce and you try too hard, you can do all sorts of damage. You can trash the S1 nerve root, S2 nerve root. You can put screws where they don't belong in the iliac vessels, and whilst trying to pull and push, you can rupture the iliacs because they bifurcate right in front of where you are. So be careful. Tumor surgery, limb salvage is the preferred option for children. We have all sorts of growing metal prosthesis for that. Just a final word. I think you should all start thinking about, if you have your little offices, how to invest in one of these things. This is a mini CM. This mini CM, some of them will actually fit into the boot of your car. Seriously. They will fit in the boot of the Jeep people will drive around, and you can carry it around from one clinic to the next. You can X-ray hands, wrists, foot. In a child, you can X-ray almost anything with this thing. So if your hand and foot practice, your pediatric practice, you can X-ray if you've got ankle fractures, wrist fractures, you can do them with this thing. So 2 or 3 surgeons working together should invest in some of these things. Buy mini CM. They don't cost very much. And if you're using a mini CM, you don't need, because the radiation that it generates is so low, you don't actually need a radiographer to use it for you or with you. You can use it by yourself. So these are extremely useful. And then you can print out paper copies of whatever images you have. So my small pep talk on pediatric orthopedics, I think is absolutely important that all our trainees have decent exposure to children's orthopedics for the centers that offer them. They probably should rotate to centers that have a decent pediatric setup, all residents, and have a period of time of pediatric training. Because of our large young population and the fact that if you can fix these things early, then it's less of a problem later on. We probably should be looking at collaborating and setting up advanced training programs for children's orthopedics. We already have one in Cedar-Crest, where anyone who's just finishing the FWACS can come and spend some time learning children's surgery and some of the other stuff that I do. You're very welcome to ask. This is just me reminding us that we probably need to engage with the community a bit better. To be honest, I think the crippling that goes on of our citizens by bone setters is not going to stop if we don't engage with them in some way. At least try to make them safe. We might not make them effective or improve their practice, but at least we can stop them from having people cut their legs off. And just a final word. I think that together we can achieve more. I'll just remind everybody about something that's close to my heart. This is Cedar-Crest Gaius Foundation. This is where we treat all the young people who don't have any. They are very welcome to help us with this. So if you have anybody who needs specialized pediatric orthopedic care, refer them there. But of course, when you are referring them there, also remember to send some naira with it so we can use it to treat the child. It doesn't pay me. I don't get any fees for treating children on Gaius. All professional fees are cancelled for Gaius patients. It's just for consumables and stuff. And it's been wonderful talking to you guys. Thank you very much for your time, and I'll take questions.
Thank you very much for your talk. Can you hear me?
Yeah, I can hear you well.
Oh, good. Sorry, I had some audio issues for a bit of time during the course of the talk. Thank you very much for a very nice overview of the subspecialty, so to speak, and also the issues on training, which I think are quite pertinent to our own environment. If there are questions or comments now, can we have them written out in the chat boxes?
Hello, Kemi. Can someone? Hello, Kemi.
Hello, I can hear you.
Yeah, someone sent a question to me. Can I ask him?
Please go ahead.
Yeah, I believe the question came because of that picture you posted about the Blounts.
Yeah.
The attempt at hemiepiphysiodesis.
Yes.
The guy wants to know the principles behind it. How do you put the screws? Do you converge? Do you diverge? And when do you abort mission?
Oh.
I couldn't tell him this talk is not about hemiepiphysiodesis. But I mean, if we can clear the doubt, it won't be a bad idea, sir.
I don't even know where to start to answer that question. Well, is he talking about this?
Yes.
Oh dear. Well, so okay, I'll put it very simply. If you're going to put a hemiepiphysiodesis, you need to decide which side of the bone is short and which side of the bone is long. Which side of the bone do you want to stop growing? Which side of the bone do you want to continue growing? So those are the two questions you need to ask yourself. Who's long, who's short? Who do you want to stop growing? Usually the long side. Who do you want to continue growing? Usually the short side. Got it. So on this side, on this slide, so you've got your distal femur. Now, which part of this femur is the long side? Okay, this is the long side. Which side of this femur is the short side? This is the short side. So if you want this bone to correct, which side should you slow down the growth? Well, you slow down the growth of the long side so the short side can catch up. So you put your plate here, okay, so that that side can continue to grow and catch up. And if you wanted to use a plate here, this is the short side, this is the long side. So you put your plate here. But unfortunately, on this particular bone, that's frozen. That's never going to grow again. So your 8th plate is not going to do anything. The best it can do is maintain the status quo. But if you then go and do the opposite and put the 8th plate on the short side, where the long side continues to grow even longer, and your deformity gets worse, and the whole knee joint falls off. It completely subluxes. Okay? In terms of how do you place the screws, I would just place my screws parallel. Okay? You put your screws parallel. Is it trying to converge and diverge and converge and then you confuse yourself? Don't confuse yourself. Just put parallel screws in. If you can manage to put 2 screws in, of course, this guy has put screws in and he's managed to miss the growth plate, but he's put it on wrong. It's like you, and it's happened before, you know. I don't know whether you people read the news about last year or year before, maybe year before lockdown. Some people got into plane. I think it was London. They were supposed to fly to Edinburgh. They landed in Dusseldorf, a BA plane. It happened. So don't fly to the wrong country. This is what has happened here. Okay. So the screws have been put in properly. It's in completely the wrong place. They have landed at the wrong airport. So you won't get the right result. So the knee is dislocated, subluxated now. So converge, diverge, it's irrelevant, completely irrelevant. Just put straight screws in, miss the growth plate, put it in properly, and put it on the correct side of the growth plate. And hopefully you might get the kind of result you're looking for. I hope that answers the question a little bit.
Thank you very much. Dr. Shubodi, if we have any further questions about this question from the person who's reached out to you, we'll be happy to have that as well. Dr. Aguam has said, thank you, sir, for the overview of pediatric orthopedics. We're just waiting for more questions, if there are any. In the meantime, I was going to speak about, just chat about screening for hip dislocations in our patients. And say, I think perhaps the way forward for us, like you alluded to, is to focus more on clinical screening, which already the pediatricians do. Now, how much in terms of training they receive might be something for us as orthopedic surgeons to sort of look into, because when the hips are missed, then it does become a problem. So I don't think it's asking too much to say we should sort of keep an eye on what they know and be happy to help out with neonatal screening in our centers in some way, even if it's just training, if we don't commit the time to it. What do you think about these?
Is that a question for the general audience?
Well, just a comment on perhaps what we could do in terms of screening. Because at present, I don't know about other centers, but I don't think that orthopedic surgeons are involved in newborn hip screenings at all. Well, it would be nice to know what other people think and what happens in different centers in this regard.
Are there any centers in Nigeria, I mean, this is a question out to the whole audience, that do screen for DDH hips, dislocated hips in children? Does it happen in any of the centers in the country? I mean, there's quite a few people on the platform. I don't know if anyone does any screening at all, either screening, universal screening, or screening at risk babies, multiple pregnancies, breech presentation, the usual patients that are at risk of having a hip dislocation of dysplasia. Does any screening take place?
I know in Ibadan we used to screen well then as an intern in pediatrics. You screen the newborns that are delivered. It was just part of their own protocols then. Now, what exactly I was screening for as an intern, believe you me, I'm not quite sure I knew. I suppose I was lucky, or I would never know if I was always lucky not to miss a dislocated hip. But that was as far as I know. I don't know if there are any other participants who want to unmute themselves and contribute to this and just say what happens in different places. But while we're waiting for that, do we have any other questions? Okay, feels like a very quiet house today. Well, thank you once again for your lecture.
Sorry, there's Ramadan perhaps. Okay, if I could also add, sir. Sir, is Oga still there?
Go ahead, yes.
Yeah, I mean, it's also important to stress that for the benefit of the gentleman that is listening, I have sent the text to him, although I've sent the text to him, but for the benefit of the residents that might be.
We've lost you, Shobody.
Am I still here, sir?
Yeah, you're back, but we lost you, so you've got to start again.
Yes, I was trying to add, sir, for the benefit of the answer to the gentleman, even though I told him to still listen up in class. Yes.
Yeah, I mean, I think his question is perfectly valid. He just wanted to know. I think the only thing I don't understand about his question, the only thing I didn't understand about his question is whether he knew what the indications were for the 8 plate and where to put it. Because that's not a question I can quickly.
I just wanted you to go through it. What is the principle behind it? Hilter Volkmann's. You already stated clearly, where do you put it? How do you put it?
Yes.
You said it doesn't matter whether you diverge, parallel, or you converge. Yes. It's also important to state that it works on the proliferative as well as the hypertrophic zone of the physis. Do you encourage weight bearing immediately after putting it? Do you put a cast? When do you stop? When do you abort mission? That's way.
I wish I had written the question down properly so I could see it. No, once you put the 8 plate on the tibia, you can work on it or femur. They walk out of hospital the same day. So if you haven't done an osteotomy of the tibia as well as the 8 plate, then they can work on it right away. That's number one. Number two, you have to have enough growth remaining for the 8 plates to work. There's no point putting an 8 plate like the picture that I showed him. There's no point putting an 8 plate on that tibia because there's a growth arrest on the other side. So it's a contraindication for 8 plate. So here, that's already fused. So your 8 plate is not going to do anything. It just got worse. And here, you put the 8 plate on the wrong side. So it's just going to, so both 8 plates this one maybe didn't do any harm, but this did a lot of harm. Just made the femur deformity get worse. So you need to know where to put it, how to put it, and where not to put. Actually, far more important than where to put it is where not to put it, as far as 8 plate is concerned. And I have to remind myself about this all the time. In fact, I'll give you an example. I had a patient who has lots of deformities and had to have a femoral osteotomy done. So I told my senior registrar, the patient had already had 8 plates done. So I think I put the 8 plates on femur and tibia to correct really bad, I think it was valgus deformity. So the legs were now straight. So I told the registrar, take out the 8 plates, and when you get to the femoral osteotomy, I'll join you and we will do the femoral osteotomy together. Just, you know how registrars want to operate. You don't let them touch knife, they start shouting. So I said, okay, yeah, start operating now. So I was just waiting because he's a very senior registrar. So I was waiting in the coffee room for him to finish so I could go and do the osteotomy with him. So I then go in to do the osteotomy, the femoral osteotomy. Have you taken out the plate? Say he had. I looked at the scar. The scar looked a little bit shorter than I thought it should be. And you know how trainees are like and younger surgeons. They always want to make small cuts. You know, a small cut until they get into enough trouble, and the more trouble they get into, the bigger the cut gets. You know, you can tell who's been in enough trouble. They make big cuts. So anyway, so I say, okay, bring the X-ray, bring the CME. Let me take an X-ray. You know. So I took an X-ray. Turns out this guy left the 8th plate on the femur. They only took the tibia out. And meanwhile, he did the consent himself to take out the whole thing. So if I hadn't checked, what would have simply happened is I would think he's taken out all the 8 plates. He would have told me he's taken out all the 8 plates. And what would have happened is we would now take an X-ray. A year later, this child's knee would have become bow leg. And then we will now, why is this thing still deforming? We took out all the 8 plates. Then we will take an X-ray and we'll find out that we left part of the 8 plates. And wahala for everybody. So 8 plates, when to take them out, when to put them in, how to put them in, when not to put them in. And you mustn't forget that when it's time to take it out, you must take it out. If you wait too long, you get an opposite deformity. And sometimes they're not indicated. In this particular patient, 8 plates are not indicated. So it's a wrong thing to do. It doesn't work.
Thank you very much. I hope that was useful for the doctor asking, and if not, we're still happy to provide further clarification. Meanwhile, Dr. Okechukwu says, is there a place for open reduction and K-wire fixation of supracondylar fractures in children where there's no CM?
Huh. Yeah, I know where that question is coming from. Can we do an open reduction and K-wire fixation in supracondylar fracture in children where there's no CM? The straightforward answer to that is yes, you can. The next question that I would ask is, why do you want to do that? If I was to do an open reduction in a child with a supracondylar fracture, then I would be doing a posterior approach. I would reduce it posteriorly, and I'll put K-wires in medial and lateral, or 2 lateral K-wires. But to be honest, given what I know now, and given the benefit of experience, and given the benefit of seeing lots and lots and lots and lots of things go wrong, if you had a choice between just putting the child in an extension splint, a bit of traction, traction over, you can actually do some traction, like a traction over the edge of the bed, over a drip stand, something like that, on a child for a few days. Once that elbow is reduced, you then put them in a long splint and send them home. That'll take about 2 or 3 days, and then put them in a long splint and send them home. If I had the choice between doing that and doing an open reduction posterior approach with K wires, I would put the child on traction and then put it in the back splint. If I don't have a CM and a proper driver to put K wires in to do a proper close reduction. So that's me. That's how I think about it. Over the years I've done this. I think it's safer for the child and safer for everybody if you did that traction for a while, get it reduced, put it in a long splint. You will get a certain amount of varus, cubitus valgus, or whatever, and then you would get children, because especially with the type 3 supracondylar fractures where it's healed posteriorly, you will lose flexion for a while because it's posteriorly translated, the distal fragment. But that flexion will come. If you give the child 18 months, you get most of that flexion back. So if you ask me, should you do it? I wouldn't say don't do it. I would just say that, look, the results you get from if something were to go wrong, you get it infected, you don't get it pained quite enough, well enough, and all that. I'm not sure it's worth the hassle for the child personally. I don't think so. And that's from seeing lots and lots of things go wrong. So that's the answer to that question. Somebody's commented here that a large proportion of that they think their pediatricians screen their children, Dr. Anabo, but she says, I don't, or he, I don't know whether it's he or she, say, I don't know who teaches them to screen though. Well, we should teach them how to screen for DDH. It's our job to teach them how to screen for it. But she says there's a large population of children born outside the teaching hospital setting, and I don't know what happens to them. And we don't know either. So these are some of the jobs that the Pediatric Orthopedic Society of Nigeria should be putting to one side and deciding how they want to solve those problems. You know, do they want to start teaching? Do they want to train all medical students how to do screening for DDH? And these are some of the questions we need to ask ourselves. You know, how does the magnet work whilst using the intramedullary lengthening device? I think it's like you generate a force field and force. You know that if you put a magnet with negative and negative together, they repel each other. And I think that magnet that you put on top of it generates a current in the metal that allows it to become negative and negative. So they repel by a certain amount. And then you turn it off, it stays there. The next day when you put it back on, it's negative and negative again. They repel a bit more like that. I think it's something to do with that. Dr. Shobode, you might know. Have you used any of these lengthening rods on the spine?
Yes, magic rod.
How does it work? Answer the question now.
Hello?
Is it rod?
Hello?
Maybe my explanation might not be good enough. Answer, how does
it is.
How does it work?
You preset the magic rod to the length you want to get. Usually we do this every 3 months or every 6 months. Every 3 months for patients that live within the vicinity, and every 6 months for patients that live far away. It's already set in. The rod has a swelling like
yes,
like normal, like a plexus.
Yes.
A swelling of a plexus. It has a swelling that is charged, negatively charged or positively charged, as the case may be, on both sides. The two, there are two swellings on the rod, on the two rods. Okay, and the distractor or the machine that you place at the back of the patient.
Correct.
Negative will distract, positive will distract. So as you just turn on the machine and it starts making a sound, like kind of sound you hear from an MRI machine, but not as distressing as that. Yes. It just makes the sound. It doesn't last more than 2 minutes. You're done distracting.
It's short. It's quite short. Yes.
Yes.
So basically, it creates.
It's called the magic. It's called the magic, sir.
It creates a charge on both ends that repel each other. So it forces the rod apart. That's what it does.
Yes.
Yes, that's how it works.
And also, sir, you talked about the vertebral body tethering. We call it VBT in scoliosis.
Are you guys doing any of that?
Well, I've seen like 10 when I was in Italy, but most surgeons.
What's stopping us doing it?
Sir?
What's stopping us doing it? Because we don't have the thoracic backup.
It is expensive.
Oh, okay. Same problem.
A VBT surgery will cost nothing less than $80,000 US.
How much is the equipment itself?
If the surgery can cost that much, sir, I can begin to imagine what the equipment will cost, sir.
So in that case, if I may ask, your lengthening rods for the spine, how much is the rods? How much are you getting the rods for? Because
there is only one center. A magic rod costs as much as $75,000 US. So 2 rods, that's $150,000. And there's only one center in Africa that does the magic rod, and that is Ghana. And you
haven't done it in Kano yet.
There's only one center in Africa, sir. That's focus in Ghana.
Okay, so I thought when you were talking, I thought you were doing it in Kano. Sorry.
I was there for training for 3 months, so I saw we did it a lot. And apart from that, there are just about 10 centers in the world that does magic rod.
No, 10. because I was hoping we could bring the magnetic rods for femurs and tibias and the long bones, but they are quite there. It's about £15,000, probably more. If once you say you are bringing it to Africa, no one wants to talk to you. That's a problem. Oh, it's a big problem. So we have to try harder. Dr. Lashebikon wants to know, can we improvise an abduction brace after uses of public harness for DDH treatment? Yes, we can. Actually quite easy to make. Unfortunately, I haven't put a picture of it there, but I will send you a picture. If you remind me, just send me a WhatsApp text. I'll find the picture and I'll send it to you, and then you can get somebody to make one for you. It should be easy enough to make. It can't be too difficult.
Great. So we have 15 more minutes to 6. And Dr. Nwoye says, thank you, sir. Excellent overview. I don't know if there are any other questions coming in. Dr. Lashibika as well has also said thank you. I suppose your comment, it's a recurring theme on us needing more data and on the way to get more data. Now, this is speaking as somebody who has gone through the process of doing dissertations, and all of that. Part of the trouble that residents face is there's quite a bit of restriction on what you can do as a dissertation, and nobody wants to be the person to spend 6 months to try and see if a new type of topic will fly. Essentially, you have to measure something, but we're not quite clear over what is epidemiologic and what is not epidemiologic. And while we need a lot of epidemiologic data, and they do involve measurement, not all of them will involve you actively giving an intervention. And this stops residents and trainees from being able to pick up the slack of some of this work that really needs to be done. So I suppose that's not a problem we can fix. It would be something for those in the colleges to look into. Because as a trainee, you just want a short topic that would fly, so to speak, and get your F-works and do anything fancy, you're looking for trouble. So why do it? But perhaps as non-trainees, there's still a lot that can be done in terms of us actively working to gather data about our own populations. So it's probably more a problem for fellows rather than for residents, because the residents just want to pass, really, and you can hardly blame them. It's hard enough as it is. I wonder if there are any questions, or we can proceed to
Yes,
round up the
sorry,
meeting.
before you run away, Kemi. Sir, Doctor, well, I don't know if he wants me to mention his name. It's a private message. He wants to know if you can I assume this excludes a tenotomy. If you can break down the surgeries and when you do these surgeries in just a summary of it for clubfoot. Well, I'm paraphrasing what he sent to me, and I'm assuming this does not include tenotomy. Hello, Oga, did you hear me, sir? Hello, sir.
Yeah, I can hear you. I can hear you. Sorry. Sorry, I didn't press the right button. Somebody was accidentally unmuted himself. I wanted to understand because I've gone through lots of different things. Which particular surgery are you talking about?
For clubfoot.
So he wants to know, and what is the question?
Okay. Yes, the question is quite confusing to me. Can you summarize the surgeries you do for clubfoot? When do you do it, and what is desirable? And I am assuming this does not include a tenotomy.
Yes. Yeah, you're probably right that it doesn't include it.
Okay, so let me help him. Let me help him to understand this, or put it in perspective, sir.
No, I think I understand the question. I think I understand.
Oh, okay, sir. Okay,
I think I understand the question, and I understand the question from the point of view of, the trouble is, we started doing clubfoot surgery, Ponseti casting for clubfoot, and the trouble with the difference between us and the people that brought Ponseti, say the Iowa people, for example, is follow-up. We make a lot of noise about our achievements, and rightly so. But one of the things that we keep forgetting is the fact that we don't follow up our patients like these people have done. If you give a patient a follow-up appointment for 10 years in Iowa, they will come back. They always, that's why they've got all the long, nice follow-ups for their prosthetic treatment and also for their spine. If you look at scoliosis and all the natural history studies for scoliosis, they were done in Iowa. That's because the patients will come back for follow-up. 20, 30 years later, they'll come back for follow-up. It's a population of people that didn't move. They didn't move very much. They didn't leave Iowa. They didn't go anywhere else. So it was a really great group for studying natural history. Going back to clubfoot, if you read Ponsetti's little green book, he will tell you that 60% of his patients had to have a tenotomy. When we started doing clubfoot, a lot of us weren't doing enough tenotomies. And we thought that was a good thing, that we were not doing, or we're getting away without doing as much tenotomies. But we had a lot more recurrences, and now we've gone to, there's a lot more tenotomies going on now than used to be the case 5-6 years ago. Moving forwards again, if you go to any of the big children's orthopedic centers in the US, you will find that a lot of the children, and I follow up my clubfoot till skeletal maturity, till they're adults. If you don't follow up you cannot tell me that you don't have recurrence if you do not follow up your clubfoot until skeletal maturity. You don't know what your recurrence rate is, period. You do not know. Just because your patient doesn't come back to clinic for follow-up doesn't mean that they're okay. There's plenty of reasons why they may not come back. If you've done 1, 2, 3 procedures and they're not better, they won't come back now, especially if they have to pay every time. They may not come back because they just don't want the hassle of you treating them again, or because they have to pay and they don't have the money. So the fact that they haven't come back doesn't mean you don't have recurrence. So ideally, we don't know what our 5-year, what our 10-year recurrence rate for clubfoot surgery is in Nigeria. And I don't know that anyone has done that study looking at all his patients 5 years later, 10 years later. That's what we don't have, that other people that have been doing it before us have. And if you look at a lot of these other people, you'll find out that their recurrence rate varies between 20 and 30%. This is where this surgery my colleague is talking about comes in. So a lot of the patients who've had clubfoot surgery, they come back 5-6 years later. You repeat your Ponseti, you will find out that the lateral column is longer than the medial column. That's why you have to think in terms of the concepts of lateral column shortening and medial column lengthening. And there are lots and lots of different ways to do it. And that really is the summary of the surgery. Lateral column shortening, medial column lengthening, and then something to get the foot out of equinus. Especially if you got a flat top talus, sometimes you may have to do, apart from the Achilles tendon lengthening, you may have to release the posterior capsule of the ankle joint and posterior capsule of the subtalar joint to get the foot back into a plantigrade position. So medial column lengthening, lateral column shortening, posterior capsule of the ankle release, and posterior release of the subtalar joint. When you're doing all this, often you may have to lengthen the tibialis posterior tendon as well, in addition to moving the tibialis anterior tendon to the lateral side of the foot. We'll talk about moving it into the medial lateral cuneiform. I generally move my tibialis anterior tendon into the cuboid because most of the time in these patients that you're moving, if it's one of those nice club foot that you caught early, they responded well to treatment, they're intoing at 5 and 6 years old, and you want to do a simple, and they don't have an equinus deformity, you want to do a simple tibialis anterior tendon transfer, you can move that into the lateral cuneiform. If it's one of the more serious ones that we see in Africa, where the whole foot is tilted sideways, you don't quite have a plantigrade foot, you cast for a little while, the heel comes down a bit, not quite completely, and you know you're not going to win without a tibialis anterior tendon transfer. So you do a TL lengthening, and I think I did a couple with Lash last month in Abuja. You do a tibialis anterior tendon transfer to the lateral side of the foot. You do a lateral wedge osteotomy of the cuboid, and you put the tendon inside that cuboid that you have now osteotomized and shortened. So there's a lateral shortening. In addition to that, you may well have to osteotomize the medial cuneiform, an open wedge, to lengthen the medial column sometimes. And on the other side of this same patient that we have done a cuboid decancellization osteotomy, that didn't correct the deformity fully. So we had to do a supramalleolar osteotomy of the tibia to get the foot into a plantigrade position. So the surgery is a la carte. There's lots and lots and lots of different things you need to know how to do to get the foot right when the foot needs surgery. They won't all need surgery, but a decent proportion of feet will need surgery. 20% over 5 years will need some form of surgery. And you better know what you need to do when the children come back and they want their surgery. They will start coming back. We're doing Ponseti well. Now, the trouble with doing Ponseti well is they now know that there's a doctor that's treating this thing. So you need to go and learn what you're going to do with your recurrences when they come back, because they will come back. We started doing Ponseti a lot 5, 6, 7 years ago. So we're now reaching the stage where your recurrences will soon start coming back. So you need to know what to do for them.
Thank you very much for that broad and detailed overview. We're 4 minutes to closure. I don't suppose there are any other questions, but just in case you have questions, please feel free to post these on any of the platforms. We have the Pediatric Orthopedic WhatsApp group. We have the trainees Telegram group as well. You can send your questions and comments and so forth to Dr. Shubode or to myself, and we will definitely get answers for you from any speaker you wish to reach out to. The other thing to say is tomorrow we're having a talk on cerebral palsy, which I'm particularly excited about because the speaker certainly has some 20, maybe 30 years of experience looking after patients with cerebral palsy, including developing gait scores and systems and so forth. So it would be very useful for everyone to be present. Having said that, in the absence of anything else, may I close the meeting, sirs?
Yes, you can. Thank you very much.
Yes, Auntie.
So that Dr. Shubode can go and break his fast. We're getting to that. Anyway, we're all fasting together with you, sir, at least in spirit.
Yeah, thank you. And thanks for terrorizing me earlier today with your culinary skills. I appreciate.
No, it's well, what are friends for?
You can say that
Anyway,
again. Thank you.
We'll all catch up tomorrow. I want to appreciate particularly the people who have come here fasting. And thank you for your continued support and presence and participation. And I know that yes, we're going to have a great Nigerian orthopedics, and it only just keeps getting better. So see you all tomorrow, same time. Have a good evening.
Yeah, you too. Bye. Bye.
Thank you. Bye-bye.
Thank you.
Thanks. Thank you.